Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Today, we hear from a physician on the front lines of respiratory virus season. Dr. Wendie Grader-Beck is an internist and pediatrician who has been trying to protect children against RSV by prescribing a new immunization recently approved by the FDA. She speaks with Dr. Josh Sharfstein about what's happened as her high hopes have collided with the reality of product shortages and other hurdles. Let's listen.
Dr. Wendie Grader-Beck, it is great to see you and to have you here with me on Public Health on Call to talk about RSV and products to protect babies. How are you doing today?
I'm great. Thank you so much for having me, Josh.
So you are an internist and a pediatrician. Tell me a little bit about your practice.
So I see all ages. I work in an outpatient setting that's a part of the University of Maryland Medical System. I have patients that are just coming out of the hospital, newborns, a few days old, all the way up to patients that are 101.
That is pretty great. I remember that we learned together about all those ages in medical school, but not everyone actually takes care of patients from 0 to 101 in practice.
Well, it's really fun.
So we're going to talk about RSV, respiratory syncytial virus, and how it affects little babies particularly. It also affects older adults and potentially that 101-year-old patient of yours. But really, we're going to talk about babies today. Could you tell me a little bit about RSV disease in infants?
Yes. So for the vast majority of infants, RSV is a cold. And so it starts out with a runny nose. Sometimes there can be some sneezing, some nasal congestion. Sometimes there can be a red eye or pink eye for babies. And that's mild RSV. And then unfortunately, RSV can track down into the lower respiratory tract, down to the lungs. And for those unfortunate babies, they can get RSV bronchiolitis, which can cause some wheezing and some increased work of breathing. And sometimes those babies can get sick enough that they need to stay in the hospital to be cared for.
And which babies are at particular risk for severe disease?
So all babies in their first RSV season are at risk for developing severe RSV. Babies that are premature, where their lungs didn't fully develop before they were birthed, have an increased risk for severe RSV, along with babies that are not breastfed. And so it does look like having antibodies is very helpful to protect you against severe RSV, although it does not prevent the minor cold symptoms that RSV can cause. And I think what I should just mention to lay the background for RSV is that it is the most common reason for a sick visit to a pediatrician or to an emergency room department for a baby under 2 years old during RSV season.
So I'm hearing you that the key for RSV in babies is antibodies. If babies don't have them because they're so young, they're at more risk for severe disease. But if they do have them, they're at less risk. And so we're going to talk about how to get those antibodies to babies. There are a couple new products out there.
Yes. So there's one primary product that's directed for babies themselves, for infants, and that is a long-acting antibody, nirsevimab, and that's a monoclonal antibody that is given to a baby as soon as they are born, as they're entering their first RSV season, and that one-time dose will deliver enough antibodies to protect babies against developing severe RSV or hospitalizations for RSV. There's another product that is geared to the pregnant mother, and that is a vaccine that's given to mothers when they're pregnant to deliver antibodies so that when the baby's born, the baby has antibody, and that's called Abrysvo.
Got it. So in some cases, since you are not an obstetrician, gynecologist, you'll see a baby and the baby may be already protected because the parent has gotten the antibody shot directly. But in other cases, you're seeing babies who don't have antibodies, are vulnerable to RSV, and you're looking at them and now you're excited to protect them.
Yes, absolutely. The FDA approved this new long-acting monoclonal antibody in July. And then in August was when the CDC recommended this. And it was very exciting to watch this happen because that looked like it was going to be enough time for the 2023 RSV season, which usually happens around the same time as influenza. So that's starting in the late autumn through winter.
Would it be fair to say that you had high hopes for this RSV season?
Absolutely. The best hopes, because we've never had protection for all infants for RSV before. So this was really a new opportunity for all babies to protect them, to prevent them from needing to be seen, in the pediatrician's office when they're sick, and urgent cares when they're sick, in the emergency rooms, preventing hospitalizations. So it's a really wonderful opportunity to prevent an illness, and which is what pediatricians are really excited to do, is to keep babies healthy and keep children healthy.
Got it. Now, I know there's an internet meme, which is like how it started and how it's going. So I guess I'm going to ask you, how is it going?
Well, I would say that for the high hopes for this year have been dashed in the lack of availability for the product for the vast majority of patients. So initially, this was going to be for all babies that were under 8 months old. However, there was a shortage in terms of availability, and there's 2 doses. So for babies that are under 5 kilos, there's a 50 milligram dose. And then if they're more than 5 kilos, and that's usually happens somewhere around 2 months or so, the babies are then going to be getting the higher dose, the 100 milligram dose. So it has been incredibly difficult to find the higher dose, the 100 milligram dose. And so for some of my parents that I had mentioned that this was going to be happening, and I, at that time, did verbal orders into their pharmacies because there was no way for our electronic medical record to do anything electronically yet because it was just being approved. We were hoping that those babies would be able to receive the vaccine, but there was no availability. And then by the time there was a very low availability, some of these babies had aged out because once they realized there was such a shortage, really needed to take care of the most vulnerable of the vulnerable infants. And those are the babies that are high risk because they're premature, or they have another lung issue, or an immune system issue, or they are less than 6 months.
So for a lot of babies, it was so close, but yet so far during this season.
Yes. And so families had some expectation. And then I had to share the news that it wasn't just about availability. Their babies were no longer eligible for the medication because they were several months older.
But what do you think went wrong in terms of the planning or the communication?
I mean, I think it's clear in terms of population data, how many babies would require this and what the RSV season would look like for babies in that age group. And so if there was any indication early on that that need was not going to be able to be met, it would have been, I think, helpful to share that with the front line so that we couldn't set families up for expectations that we couldn't meet later. So that would be ideal.
It doesn't necessarily seem like too much to ask because, as you said, it was knowable how much would be needed for the winter. And people like you who are caring for a lot of kids could then have been in a position to manage expectations.
Yes. I think that the other piece of this is about sort of the disparities in health that come based on your insurance coverage. And I don't know if you want to talk about this as a part of what we're discussing as well.
You bet. Let me hear it.
Okay. So the wonderful news that we heard early on was that the state of Maryland understands the significant risk to babies for RSV and that they were going to approve this medication. Because my biggest concern as I learned the cost of this medication, which is $450 per dose per infant, is that it's a significant cost. And so to know right up front that the state of Maryland was going to help to pay for this medication for the most vulnerable financially vulnerable population in the state, which are babies that are eligible for vaccines for children. So these are our Medicaid eligible children and also underinsured children. So they were all going to get covered. And so knowing that was also really reassuring. And then we have our privately insured patients. And those patients in this situation were, for the vast majority, their medication wasn't getting covered fully. And so we had some babies, for instance, where the parents, I ordered the medication and the $450 medication would have $20 covered by their insurance. And so those families felt that they couldn't afford the coverage for their baby.
So on top of the supply shortages, on top of those, you had some payers not really providing much insurance coverage at all for families.
Yes. And I think the other struggle is that for a vaccine like this that I was ordering at pharmacies, because again, I think there's some struggle also with any infant vaccine that's standardly going to be delivered. So no pharmacy wants to be administering a vaccine to an infant, which I absolutely agree that should happen in a pediatrician's office. And so initially, pharmacies were reluctant to buy the medication because they would have to hand it off to the family to get administered in the office. And then because it comes in a package of 5, they want to be able to know that they have 5 well enough insured infants that are going to cover that medication so that the family is going to walk away with it. That is the struggle. So I did have early on, I had 2 families that were willing to pay out of pocket $450, but I didn't have enough coverage for our very local pharmacy to buy 5. And then eventually it took so long, months passed, that 2 of those babies, they were too old to be able to be eligible any longer for the vaccine because once the shortage occurred, they had aged out, really sadly.
And for the babies, it's possible to kind of know which ones are at higher risk.
Yes. I mean, all babies, all infants in their first year of life during their first RSV season do have an increased risk for severe RSV. So just being a small infant, developing your immune system puts you at risk. And then babies that are premature, that are born before 40 weeks, certainly have an increased risk as well. Babies that are not breastfed have an increased risk. So almost all of us have had RSV by the time we're 2. Had it many times by the time we're adults. And having immunity doesn't protect you from getting RSV, but it does protect you from severe RSV. So it's the people that are in that very beginning who don't yet have antibodies that have the increased risk.
And can you paint a picture of what severe RSV looks like in a baby?
Okay. I mean, I think if we step back and look at what RSV looks like for most of us, it helps to start because for most of us, also for infants, RSV can start out as just a regular cold, a little bit of a runny nose or some nasal congestion, sneezing, coughing, sometimes a little bit of a red eye. For most people, RSV just looks like a cold. And then unfortunately, for severe RSV, the infection can go from just being an upper airway down into the lungs. And for those babies, they have some wheezing and they look like they're working harder to breathe.
And that can last for days.
Yes, it can last for days. And for those babies that do the worst, those babies that develop severe RSV, they can become hospitalized to help them because they're having such a hard time breathing.
So you must have been pretty excited with these new products coming onto the market to prevent severe disease in babies who are at the highest risk.
Yes, I was very excited. So there was in the past, there was a medication that you would deliver once a month to babies that were at highest risk, that were premature for their first year, and then they could get it once a month during RSV season of their second year if they had significant lung disease. But this was an opportunity for all babies, so everybody in their first season of entering their first RSV season, to get a one-time dose of a long-acting antibody that would protect them against severe RSV. So I was watching as it was developed and then watching when it got approved by the FDA and then watching for the final approval from the American Academy of Pediatrics, the CDC, watching with bated breath, very excited. The timing was right as we're approaching the RSV season that we're in right now. And initially, when all of that went through, We didn't have our electronic medical record up yet, but we could call into pharmacies to do a verbal order, which we don't usually do, just because it was such a cutting edge, beginning of availability of this new Beyfortus is what it's called.
And we should just say that there's also a treatment for people during pregnancy, which if the parent gets that treatment, then the baby doesn't need this medicine. Is that right?
Yes. For pregnant women, if they're offered and they agree to have the RSV vaccine during their pregnancy, then they will have antibodies. And so RSV is very sensitive to having antibodies. So anybody who has antibodies reduces their risk for severe COVID. So those babies would have a significantly reduced risk as well.
I hate to say it this way, but when you talk about having to juggle constantly all of your patients who are waiting for the medicine, figuring out the right pharmacy, all these extra details, it sounds incredibly frustrating.
Yes, I think it was frustrating because I had hopes and then I would hear of a success of a pharmacy and then my hopes would go up again. I think for my frustration, it's real. I think for families in particular that still did not and do not have the vaccine right now, their babies are in daycare, and we are having right now a lot of daycares with lots of RSV. It's been really hard for those families.
So you're painting a picture of some complexity. You start out with a great technological advance that can help a lot of babies avoid getting sick. And then you run into problems with the supply, communications that aren't clear, and then this packaging issue, which makes it hard for privately insured patients to be able to go to the pharmacy and actually get the medicine, really illustrates the importance of attention to implementation. Let's imagine for a moment that we're going to have a better RSV season next year from this perspective. What would you like to see?
Well, I think that I'm always very eager for clear public health messaging. Okay, so we have commercials where people find out about things from private companies, for instance, some other vaccines. But I would love to see clear public health messaging that's targeting, because these are all targeted messages, targeting families that are pregnant to get their RSV vaccine for all pregnant women. And then for families that have infants, this can happen. We have all kinds of ways to know who's buying things for babies, to have targeted messaging for these families about RSV availability so that they've heard about this before, and then to share very clear information, whether that comes through the American Academy of Pediatrics, probably ideal, through the local Maryland and other state departments of health around availability so that we can plan and know ahead of time, months ahead, if we have in stock what we're going to have. That's the ideal, is that not only do the doctors know what's going to happen, but also we're doing some individual sharing with families.
And let me add also better private insurance coverage and a more clear route for people to get this medication from the pharmacy if needed.
Yes. I think that the great news that I've seen for Medicare is that Medicare now covers any recommended vaccine in the pharmacy, but it covers it. And I think that private insurance for children needs to cover any recommended vaccine. For primary care, there's certain things that need to be covered, and I would stress strongly that recommended vaccines should be fully covered for children.
Well, Dr. Wendie Grader-Beck, thank you so much for joining me. From your lips to the world of public health, we are going to hope for a season next year that delivers on the promise of this medication to many, many more babies.
Thank you so much, Josh. It's great to be here. Thank you.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Ciceri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.